If you come late, you want to prevent it from
have a seat.
Okay, good afternoon everyone and welcome. It's my great pleasure to welcome Dr. Drabkin, who is a UCT alumnus. His main job at the moment is a section editor in family medicine at Dynamed, and he's also an assistant professor in population medicine at Harvard Medical School. And he'll be talking to us today on checking the checkboxes, critical appraisal of clinical quality measures. So at Dynamed, he's leading a large project using an innovative methodology to assess the appropriateness of clinical quality measures used in value-based physician reimbursement contracts. He's presented these findings locally, nationally and internationally in clinical evidence-based medicine and quality-related settings. He is quite a distinguished doctor, and we want to welcome him back at UCT again. It's always nice to have alumnus visiting us, especially one of good quality, and we look forward to your talk.
Thanks so much. Thanks so much. So, strange things happen in a person's life. And if you told me when I finished medical school that I'd be standing here 40 years later talking to you about the things that I might be able to talk to you about, I would have said you must be crazy. But so it goes in this wonderful profession called medicine, and in this wonderful world where opportunities show themselves and you follow them, and this is what happens. When I tell people, people ask me, what do I do? If they're a non-medical person, I say to them, well, I'm an editor in a medical textbook, and usually that's the end of the conversation. And if I'm a medical person, I'll say, well, I'm an editor in an online evidence-based medical reference tool for point-of-care use. And most people sort of can figure that out, and except that when I was in medical school, and probably for 20 or maybe even 30 years afterwards, I wouldn't have understood a single word in that sentence. So it shows you where life takes you and where opportunity takes you and what happens in the world. So all the tools that we have at our disposal here at the moment, and even some of the methodologies that we're working with at the moment, are things that are being invented and being used. So that's one of the messages. The other message I would say here is that this is a sign of the context of the collaboration between clinical medicine, evidence-based medicine, quality, policy. It's at the intersection of all those arenas. So I'm very happy to be here. I'm proud to be here. UCT is my favorite, academic institution in the world. It sent me on my way, and I'm always very grateful to it. So disclosure: I am a full-time employee on EBSCO. You've probably all seen EBSCO. It helps you, do your databases and your literature searches behind the scenes. It's a major international electronic publishing company, and I work in the medical division in a product called Dynamed Plus. I don't have any staff or any options or anything like that, but I'm an employee of the company. Aims and objectives for this morning. We want to appreciate the need for quality measures in healthcare. We want to review concerns that have been reported with quality measurement in healthcare, plenty of those. We want to review the genesis and the content of our critical appraisal methodology for evaluating the appropriateness of clinical quality measures. We want to evaluate the results of 3 different measures. I'm going to need your help, actually. Participation coming up. We are going to review the results of this appraisal of 4 sets of clinical quality measures that we've done. And we're going to review our future plans for this project, and hopefully we'll have some time after all of that for discussion. So, value of healthcare quality measures. Well, they can quantify qualitative aspects of healthcare processes, outcomes, patient perceptions, experience. These are the good things that they might bring. They can inform consumers, providers, regulators, others about the quality of healthcare being provided in a setting. They can improve effective, safe, efficient, patient-centered, equitable, and timely care if they actually function well. And they can impact positively on healthcare services and meaningful outcomes. Hopefully, longevity, quality of life, functioning. This is what we're all about. That's the possible benefits. Well, there are harms too. I wish somebody could find for me a picture of an unhappy female physician, all right? But this is the guy that I've got. Not trying to say that the only people who feel like that are older white males, but that's what's out there. Doctors don't like these quality measures. Why? Because, well, it starts affecting their professional image. They worry whether these things conflict with their values. They get frustrated because they have to report on these things all the time, not just individual doctors, but whole systems do. They have to change their behavior in order to do this. It's money. Sometimes money follows this. What if your compensation from your employer or from your insurance company, as increasingly is happening there in the States, UK, and other places, happening here too, I'm hearing in some of the sectors. Well, it affects you. They pay you more money if you do well on this. They pay you less money if you do poorly. You want to do the right thing. Everybody's in medicine to do the right thing. We all want to do the right. We want to do the best for our patients. We want to improve the health of our communities. Well, some of these things sometimes conflict with that. Well, what is quality care? It challenges the whole notion of what is quality care. Then you start dealing about your quality score. Well, am I really my quality score? Well, I lay away at night worrying about what my quality score is going to be, rather than am I worrying about how my patients are going to get better. And what's the value? What the payers are worrying about, what's the value that they're providing to the patients that they're covering. So it's very conflictual in a way. Sometimes it takes away from time with your patient because you're worrying about doing well on your quality measures rather than what the patient's actually there for, what the patient actually is needed at the time. So problems related, just to reiterate, too many administrative burdens, not sufficiently patient-centered, often assess the wrong things, we're worrying about surrogate outcomes rather than the actual things that really matter to patients, blood pressure results or test results and that sort of thing. We're ignoring social determinants of health and risk adjustment. Could create conflict between patient and clinician interests. They don't account for locus of control. You're subject to gaming. You put things down on your reports that don't really exist because you really have to match up with the quality measures that you're asked to report on. Opportunity costs. You're spending resources, time and dollars, or whatever currency on unhelpful activities that makes those resources less available for more meaningful activities. And can contribute to physician burnout. So those are possible harms. Actual more harms associated with inappropriate performance measures can be direct harms to patients. If you drop the patient's blood pressure too far, you're going to result in hypertension, hypoglycemia, falls, false positives associated with excessive screening, that's unnecessary, overdiagnosis or overtreatment of indolent conditions that are identified by screening. So, and wasteful testing, if you don't really need to, you're getting access A1Cs, access mammograms in inappropriate settings. So, we have a system in the United States that's called Medicare. It covers, huge millions, tens of millions of people. It's the biggest payer in the country. And Medicare is a new program starting this year. As you can see, the percentage of the reimbursement that's going to be tied to performance measures is starting out at a low percentage. It's going to increase to maybe 9-10% over the next 3 or 4 years. So about 10% of your, in the coming years, 10% of the reimbursement for physicians serving the largest population in the United States that gets covered is going to be at risk for either incentivized or for penalty for not performing well on these sorts of things. So we have a problem. We have an issue, and we really need to face it. So here's the intersection. You know, I'm a family doctor. I go to the family medicine annual conference. Practiced for 24 years in a local neighborhood health center in Cambridge. So lots of colleagues who are, you know, like myself, sort of clinician, attending part-time academics. We all have relationships with various medical schools. I was approached by them who said that we formed ourselves into a group of clinicians committed to better health for our patients and appropriate stewardship of healthcare resources. They want to achieve these outcomes through advocacy regarding a new generation of health quality measures. So they're advocating for quality measures that have the following characteristics. They're supported by evidence that they correlate with better health. They don't create situations where the doctor's interests conflict with those of the patients. And they acknowledge the importance of individual patient factors and promote shared decision making. There's a paper, you can check it out. It's colleagues of mine here from UMass and Harvard and BU and a whole bunch of them all together in this effort. There is some prior work on appropriateness of clinical quality measures. One is from the National Quality Forum, NQF. It's a non-profit, non-partisan, membership-based organization. They derive consensus-driven analyses and assessments of clinical quality measures in 22 areas. They have 300 of these measures that they've been through in more than 20 federal public reporting and pay-for-performance programs, as well as in private sector and state programs. They don't actually tell you when you go and look on your website. There's a very extensive process of consensus. All sorts of stakeholders come together, and it's a pretty extensive process. But they don't actually tell you what their criteria for appropriateness might be. Okay, so you can't find what they actually are, but there's discussion behind closed doors. So that's the NQF, and then there's also the American College of Physicians, which is now in on this because their members, there's a couple of 100,000 internists in the country who are affected by this, and they produce a brief narrative reviews of these measures, and they give them a thumbs up, a thumbs down. If you go on their website, that's what it actually is. It's a thumbs up, a thumbs down. Support or do not support it. The use of a particular measure in the setting. The reasons for their decision are given in the narrative review, and they've been through maybe 125 unique National Quality Foundation measures reviewed over 31 different clinical categories. So that's what the previous work has been, and our colleagues came to us and they said, they asked us for help, basically. They said, you guys at Dynamed, we have extensive experience in systematically monitoring, critically appraising, and synthesizing. It's sort of what we do, and if you look at our website, our product, you could see it. It's available all over the world. We do this for medical evidence. If you look at the content, we've done over 70,000 evidence summaries with levels of evidence from our previous conversation this morning here, the study on moderate alcohol and smaller hippocampal brain volumes would end up as a level 3 in non-clinical outcome measures, so something surrogate, not something that's clinically applicable. We do that for medical evidence. We do it for clinical guidance too. We've got over 1,500 topics in it with synthesized recommendations. So their question to us was, can you apply this kind of experience to performing systematic critical appraisal with transparent criteria to clinical quality measures? All right, nobody's done this before. So this is an example from one of our pages on efficacy of beta blockers. That's how we summarize things. It's how we give you the key information that you need. It's how we grade things up here. So we talk about our recommendations, strong, weak, and we give you a criteria for why we choose the language, why we give those kind of assessments of our recommendations. We said, well, I think we could. Nobody else has done this, so let's try. So we have an approach in which we consider the quality of evidence supporting these individual quality measures. We consider the strength of the recommendation supporting each of these, and we consider other factors critical for an appropriate implementation. So, this is what we have currently for our criteria for the appropriateness of a process measure. This means you get analyzed, or you get monitored for actually doing something for the patient or for not doing something for the patient, whatever it is. So the first criteria is that there's some convincing evidence out there that the action actually changes clinical outcomes, or for a measure requiring a lack of action, that action doesn't improve clinical outcomes. Important. You want to make sure that it actually makes something that's relevant to the patient. Secondly, that the desirable consequences of action outweigh the undesirable consequences of action. So the benefits versus harms. You want to make sure that that balance is convincing. Thirdly, you want to make sure that the desirable consequences of implementing a quality measure actually outweigh the undesirable consequences of implementation. What do you mean by that? Well, undesirable consequences could mean inappropriate use of diagnostic labels. We talk about gaming, to artificially meet or avoid the measure. You want to avoid effort shifting away from higher quality activities. You want to limit the inhibition of patient input into decision making. Fourthly, you want to make sure that the population is adequately specified with appropriate exclusion criteria. You want to make sure that the measure actually is measuring the thing where this measurement is actually mostly relevant. Because the computer, once you put things into the computer, once that happens, there's no person on the other side saying, well, I think they meant this, but not that. But you have to be make sure that the specification is very, very secure. And thirdly, that the intervention itself is adequately specified, including appropriate intervals or frequency. So some measures are processed. I want you to do something or not do something. Some measures are outcome. You want to actually measure something that happens to the patient. So what's an appropriate outcome measure? You want to measure a clinical outcome that's appropriate to your patient. Extension of life, better quality of life. Sometimes you can have a surrogate outcome where it can be used if it lies in a causal pathway to that clinical outcome. And you've got some change in the surrogate measure that actually is validated to predict the clinical outcome. You also want to make sure, again, that clinical evidence, that the clinical outcome can actually be changed by clinical team efforts, healthcare team efforts and actions. Again, the same thing with implementation. The desirable consequences have to outweigh the undesirable ones. The population needs to be adequately specified within an appropriate exclusion criteria. And your outcome must be also adequately specified, including the adequate time frame and assessment. So those are the criteria that we've come up with so far over a period of time. So they've been modified through interactions with colleagues and trying to do this in action. Our methodology for how to use these appropriateness criteria are the following. If all three are a yes, for that the measure actually meets all five of these criteria are met, then we designate the measure as meeting criteria for appropriateness. If 1, 2, and 3 are met, but not 4 or 5, then we might give it sort of an intermediate rating. Say it's appropriate, but it needs some modification. The population needs some modification, or the intervention needs some modification before this can be considered appropriate. If you don't have 1, 2, or 3, we regard this as not meeting criteria. So, again, this is represented diagrammatically. If the 3 most important things are met, then we go on to the population intervention. If everything's a yes and meets these criteria, we give it a meets criteria designation. If you're missing any one of the first 3, we go to doesn't meet. And if either one of the 4 or 5 population or intervention are not appropriate, then we say it may be appropriate and we suggest some modification to it. So, we need some participation. Sadly, the electronic polling, text-based messaging system that I installed here is not functioning here, but we can go back to the old polling system, which is called a show of hands. We'll see where we get with it. It might work. Okay. So here's one. We're gonna show 3. See what you think. This is a very common one and used in many different sets. Not just the Medicare set. The percentage of patients over 18 greater or at or greater than 18 years old who were screened for tobacco use at least once during a 2-year measurement period, and you have received documented tobacco cessation counseling intervention if you're identified as a tobacco user. Okay, so look at all your records, and they say, well, if you documented that everybody over 18 is actually been screened for tobacco, and once you documented that there's some sort of documentation about cessation counseling. All right, so here's a reminder. Here are the criteria. Action changes outcome, benefits outweigh harms, the implementation is desirable, the population is specific, and the interventions are specific. So, I'm not going to advance it yet because actually it was my response to that. Our attempt at doing this didn't work. But anyway, we ignore that. Let's go back. This is just my response. Do people think that this meets criteria for appropriateness, doesn't meet criteria for appropriateness, or needs some kind of modification? Okay. So those are the 3 options. Show of hands. Everybody who thinks this doesn't meet criteria. Doesn't.
Does not.
Anybody? Does not, okay. Anybody who thinks this should be modified in some way? Anybody who thinks this meets criteria? Most of you think that way. You want to help me and tell me why you think it doesn't meet criteria?
It doesn't meet criteria 1, so convincing evidence of action changes clinical outcomes. It doesn't meet criteria 2, which is desirable consequences of action outweigh undesirable consequences of action.
Because?
Because we don't know enough about what the undesirable consequences of inaction or action are. So I'm just taking a photo of your previous slide, which is what I'm looking at.
Okay. All right. We have a dissenter. It's good. That's the Kirsty. It's good.
Oh, Leslie, just making sure you know I'm here.
That's why we're here. It's a work in progress, right? It's a presentation, that's not a lecture. All right, so this is what we thought. This is what we think so far. After multiple iterative kind of reviews. So we think that action changes clinical outcomes, it meets the criteria, the benefit outweighs the harms, the desirable consequences outweigh the undesirable for implementation, the population is specified and the intervention is adequately specified. Why? So this is our summary. Identification of tobacco use in this population and physician counseling is associated with increased abstinence rates. Okay? So comparing physician to no advice or usual care in a Cochrane review from 2013, and you can, there's the link, you can go and see it, is associated with increased smoking cessation, 26 trials, 22,000 patients. It's kind of robust data. We've got a nice risk ratio and an NNT of about 20 to 30, which is actually not so bad. There's nothing you have to treat. In prevention, that's sort of not a bad thing. There's smoking cessation in about 5% of the control group anyway. So people decide by themselves. So anyway, that's one piece of data that we thought was pretty helpful. Compared to no intervention, this is in also another meta-analysis, brief advice to quit on medical grounds associated with increased long-term abstinence, and an analysis of 11 trials. And now sort of comparable risk ratio here, and again, for whatever reason, a very similar set of number need to treat data. So we would currently, unless you can convince us otherwise now or in the future, we're giving this a meets criteria designation. Okay? All right, how about this? Aspirin use for ischemic vascular disease. Percentage of patients over 18 years old who are discharged alive or after an acute MI, coronary artery bypass procedure or PCI in the 12 months prior to the measurement period, or we had an active diagnosis of ischemic vascular disease during the measurement period, and you had a documentation of use of aspirin or some other antithrombotic during the measurement period. So aspirin for people who've got some evidence of ischemic vascular disease. So action changes outcome, benefits outweigh harms, implementation desirable, is it the right population that this is useful for, is the intervention well enough specified? Okay, if I had the polling thing here, I would say 3 seconds to think, 1 second to hit your text message, but all right, 5 seconds to think. And everybody who thinks that this would meet our criteria or 5, please raise your hands. Everybody who thinks this does not meet criteria, please raise your hands.
I'm not criteria or some of the criteria.
No. You use go back. Yeah. It's not just the criteria, but how they fit together. Okay. Okay. So the top 3 need to fit together. You have to pass all those 3. First to say meet, most likely. Then if these 2 are well specified, then we can say you're okay. If these are not, we say maybe, but you need to modify it. Okay, so very few people thought it didn't. Okay. Whoops. Okay, polling coming up again. A couple of people thought it did. Looks like the majority of you think that there's some kind of modification is required. And that would be population, as in older people? Okay. 70, 80, 60? Don't say 60.
I'm there too, don't worry.
Which? Older? 50?
I'm guessing.
50. Because of what?
So how much? That's a group that's at more risk. I'm not sure that doing it with a population from between 18 and let's say 45.
Okay.
The benefits would be.
We're talking about people with established ischemic vascular
Yeah.
disease. Okay? We already got it. Not prevention.
Yeah.
Anybody else? The other
So where were contraindications written?
Okay, what contraindications? Does it say anything about contraindications there?
No.
That's what the measure says. Okay? We have to be very, very vigilant about it. That's what the measure says. There's no contraindications. Okay, that's one thing. Okay, so this is what we currently think. Well, action changes clinical outcomes. We'll show you some evidence for that. Benefits outweigh harms. We think so. Desirable consequences. Yeah, the data is robust and it's important outcomes that it shows. Population adequately specified. Not met, but we agree with not met, but for different reasons. We agree with Professor London here, and there's no exclusion for contraindications, but also ischemic vascular disease. You've got that diagnosis on your chart. That encompasses a whole lot of things. It's not just this or this. It's peripheral vascular disease and asymptomatic coronary artery disease. So that's all under the same rubric, okay? And if you've got one of those, the data for that is not nearly as robust as we would like to see. And the intervention, adequately specified, for sure. So, meets criteria with modifications suggested, that's what we currently have. Aspirin reduced all-cause mortality with a number needed to treat it to say about 70, increased risk for bleeding, okay, there is that risk. 111, sorry, that should be 111. Wow, amazing how the typo can creep in after so many reviews and revisions. So it's 111 there, and this is 71. Systematic review, American Journal of Medicine, 2008. 6 trials, 10,000 patients, stable cardiovascular disease, coronary artery disease, stroke, TIA. Population should be modified to exclude patients with asymptomatic coronary artery disease. Aspirin 325 milligrams a day may not reduce the risk of ischemic events and death in asymptomatic patients with carotid bruits associated with high-grade stenosis. Okay, randomized trial, 370 patients, aspirin versus placebo, 2 years, non-significant reductions in all ischemic events. Non-significant increase in stroke, MI, unstable angina, and death from vascular causes. So, stuff happened, yeah.
I like this, and it's really interesting. But my problem is that you've compared 2 different outcomes. So we now have got initially I'm going to be rated on 2 quality measures, and one is going to prevent people dying, and the other one is going to prevent people smoking, and those 2 things are not equivalent. So I'm just curious, when you say it changes a clinical outcome, why didn't you choose something like all-cause mortality or cause-specific mortality as your...
It's a fair enough criticism, right? So we've struggled with this, and we've gone backwards and forward on it. So is smoking cessation a strong enough clinical outcome? Okay, is not smoking, if you are smoking, is that a strong enough to be called an important, meaningful clinical outcome? Well, it's not. This doesn't look like death or longevity or complications, but the complications associated with continued smoking are substantial. We sort of know that, and in multiple going backwards and forwards on that. So I think in our initial review, there were more people who thought, well, it's a not met. Okay, you're either going to say not met because it doesn't meet that, then you say smoking cessation doesn't meet criteria for appropriateness as use. Eventually the pendulum is swung to say, in this world, in this criteria, we have to keep smoking cessation as a high enough priority because we know all the damage that it causes. Okay. We wish there were data on mortality. That would be great. Yes?
Does Dynamed take the evidence as given by these studies, or do you re-evaluate it?
We're re-evaluating all the time, so that's why...
So you would re-look at
the
actual odds ratio?
Absolutely.
Absolutely. I'm asking...
No, we don't re-analyze the statistics. No.
Okay, Because I'm asking because of something like mammography and mammography screening, which has gone, up, down, and so, it depends.
Depends on who's looking at it,
on
when
who's
you're looking.
looking at it.
Yeah,
It also depends on the recency of the studies.
Yeah, so we feel very confident that we either look at or we can get the most recent stuff. Okay? And if we don't have it in our database at the moment, our reference tool, we'll go find it. So we don't put anything up here unless we've really tried to go through the literature.
And it says in the Cochrane reviews, you do your own.
Yeah.
No, we don't do our own. We analyze the best that's out there. And we are interpreters of the information.
Can I follow up that question of Leslie? So then you might have, 3 saying yay, 2 saying no, there's no Cochrane review this. What do you do in that situation?
Well, we make a judgment. These are threshold-based criteria. I've told you what they are. These are the best we can come up with at the moment. We're open to refinement. We trust ourselves and the experts that we have around us also, to advise us. People with extensive experience in evidence-based medicine analysis. This is where we come. This is where we are. If people want to look at the same data and tell us that we're wrong, or that we are slightly wrong, we're open to it. And it will eventually get out there, so people can do that. Some of it is already out there. I'll show you how. Okay, so this is what I would call a sort of pre-C, or a typical Dynamed Plus summary of the evidence. And we will see this. We've already graded this level 2 evidence. I can't remember what the downgrade was, but we have a whole series of criteria for assessing risk of bias and threats to validity, that sort of thing, and we will tell you why we think it's a level 2 evidence. Okay. So patients with asymptomatic peripheral artery disease. Neither aspirin nor antioxidants appear to reduce CV events in patients with diabetes and asymptomatic PAD. Randomized trial, 4-year follow-up, BMJ 2008. Non-significant reduction in all-cause mortality. Non-significant increase in coronary artery disease mortality, or amputation of both the ankle. Okay, JAMA 2010, randomized trial, 3,300 patients, 8.2 years of follow-up. Aspirin may not reduce vascular events in patients with low ankle brachial index and without cardiovascular disease. So this is a case of finding stuff in this setting, prescribing the drug to or suggesting that you go buy the drug, it's easier, is not appropriate. All right. So, according to Professor Dinky Levitt, an old colleague of mine, you guys use A1Cs or percentages as well, the same way as we do. All right. So I left these numbers up there, but this is a very common clinical quality measure. The percentage of patients in your practice aged 18 to 75 years with diabetes whose most recent A1C is greater than 9 or is missing a result, and or for whom an A1C was not done during the measurement year. Okay? So, 9%. There isn't a result. There wasn't one done. Here are your criteria again. Actions changes outcome. Benefit outweighs harms. Implementation desirable. All of those 3 things have to be good for us to move ahead with a possible yes vote. Population and intervention well specified. 5 seconds to think, 1 second to vote. Oh, I should leave it up there. Oops. Okay, so those who think that this is an appropriate clinical quality measure. I'm not sure if that's a vote or
No,
an
it's not
objection.
but I'm going to come. No, it's not an objection. I've got a question after voting.
So that's a vote. It's a question after the vote. Okay, we've got 3 criteria there. All right. So meets criteria. Yeah, your 1C should be below 9. Is that a good thing? Yes. If it's above 9, is that a bad thing?
Bad.
Benefits outweigh harms. Better to get your patients' A1Cs down below 9. Implementation desirable. Doctors should work hard to do this. Right? Population, adults with diabetes. And intervention, well, it's not really an intervention, it's an outcome. Right? All right. So, here we go. We currently think that, actually left it up there.
Didn't do the vote.
Oh.
Didn't do the vote.
I thought so lots of minutes.
No,
Okay.
you only did one.
Whoops. Everybody said meats. There were a lot of notes. Meats? Hands. I don't see heads. I can't count them. Meats. 1, 2, 3 meats. 4 meats. 5 meats. All right. I feel like an auctioneer. Well, you can't. You have to vote, and then you can have questions. It's like what we did in America. Oh my God, what have we done? What have we done? You can't believe what we've done. All right. So meats with modification. Okay, a couple there. I'm going to ask you why, and doesn't meet. Nobody. There are a lot of people not voting. You cannot not vote. How many times do we have to learn the lesson? All right. So, measuring a clinical outcome important to patients. What's the difference between 9.5 and 8.5? I worked really, really hard. I gave you lots of medicine. You got sick. You didn't like them. You didn't take medicine. You didn't like me. You didn't come back. Convincing evidence that clinical outcome can be changed. Yeah, you can change it. We can go after you. We can try to bring you back in. We can do stuff. We can send you to the nurse. We can dietitian. We can give you exercise. All that sort of stuff. You sat at 9.2. You cost me something. Desirable consequences of the implementation outweigh. How many times do people want to give people medication that made them not feel so good? For what purpose? Population adequately specified. This doesn't matter now because we got 2 out of the top 3 that don't work. Exclude patients with life-limiting illness. Who cares? Okay, who cares? So you've got long-standing cancer, whatever. What does it matter whether you're A1C is? Bad heart failure, whatever. Okay, doesn't meet criteria. This is very common. It's a very common measure. It's a very common issue. It comes up. Don't go chasing the surrogate measure unless that measure is well established to be linked with clinical outcomes in the extension of it. So it's true. Higher A1Cs are associated with adverse clinical outcomes, but there's no evidence for a specific cutoff or threshold value, or target, or measure for good control, poor control. Hemoglobin A1C is not in the causal pathway of treatment and clinical outcome effects. No studies we have done, nobody's done any studies comparing more versus less intensive glycemic control, comparing a target of less than 9 versus a target of over 9. No such evidence for that such effect on clinical outcomes. We actually know if you're in the ICU, you get, whatever your A1Cs, your sugars up, you should not treat to low levels. It's bad for you.
Sorry,
Okay.
what level of evidence was that based on?
There are no studies for the threshold. The studies for people in the ICU, there's a lot of data. That's a really, really sick patient. Do not drop their blood sugar. You can't really control someone's A1C when they're in the hospital, but for some sort of bad, surgical thing. But there's no real data on, less than 9 is better than more than 9. Or less than 8.5 is better than more, or less than 9.5, whatever figure you use. Data control is actually good. But the actual threshold, the cutoff that you're going to measure people on and incentivize them on and penalize them on is nothing better.
So the American Diabetic Association, as well as the South African Diabetic Association, uses 7.1.
7.1, yes.
As the incentive-driven.
Okay.
And that's based on evidence as well. So
I would like to see that evidence. We're happy to see it. We're happy to take a look. Okay, and we have to be very careful what we go up against. We've actually just gone through this with an EBM expert who's here at the Global Evidence Summit, which is why I'm here. Bless their hearts, I've got a project that I could come to Cape Town to present. Can you believe it? There's got to be like some angel sitting here. But anyway, he said, well, but the guidelines say this and the guidelines say that. This is how we think about guidelines. We respect the guidelines. All good people want to try hard. Everybody's trying hard to do the right thing, to say the right thing. We don't use the guidelines as evidence. It's a different thing. We go to the data. And we may come to look at the same things that they've looked at and come to different conclusions. It's the same way we approach articles. The articles have methods, abstract, methodology, results, conclusion. When I was a clinician, all I was interested in is what's the conclusion. These days, when we do this work, I don't care about what they say what the conclusion is. We go straight to the methodology. Whoops, I've got to go. Okay, questions come later. Desirable consequences, potential, undesirable consequences, overtreatment, side effects, patient selection. Potential desirable consequences are not certain to outweigh these undesirable ones. Okay, so we actually have 2 topics live at the moment in Dynamed. Dynamed Plus, if you can get it, you can go look at it if you want. One is on diabetes, one is on heart failure. So we've aggregated all our current thinking about the measures in those 2 categories. That's not the end of it, but we'll show you what we do. We've got our criteria here. Actually, this is we're catching up with ourselves. Yes, we're actually, it's a former version of these criteria. But anyway, that's what it looks like. This is the evidence rationale. It's the whole thing about diabetes. We'll show you what the actual evidence shows. That's what we care about. What does the actual evidence show? Not what some. There's a difference between evidence-based medicine and eminence-based medicine. I grew up in mostly evidence-based medicine. A lot of the world does. Go to Asia and talk about this, which I've done. Korea, Japan, China. It's hard. Okay. In our diabetes set, this is what it looks like. 42 measures, 15 don't meet criteria. In a heart failure, this is what a heart failure set looks like. Again, rationale, very detailed. Heart failure, 21 measures. We've got most of them actually we think need modification. Cardiologists are very good about doing their evidence-based stuff well. Blue Cross Blue Shield Alternative Quality Contract is what got us started. We looked at 16 measures out at University of Massachusetts Hospital. We found, a minority actually met criteria, only small numbers. The Accountable Care Organization, this is again, a little bit better, but we don't want anything here if we can avoid it. So some examples from this big set that we're looking at here: criteria not met, modification suggested, viral load suppression, yes; tobacco, yes. And here's aspirin, appearing there too. So plans for the project. We're actually about halfway through, or just over halfway through, looking at all 271 measures of the MIPS program for Medicare, which is just started being implemented across 28 specialties during the course of beginning of January the 1st of this year and moving forward. So we're in the middle of doing this, but these are some of the results from our earliest evaluations. We've presented this in both clinical settings, different grand rounds, different hospitals. Come here to the evidence-based medicine world is getting to hear about it on Saturday. And we've also presented it actually at CMS, which is the government organization, agency that runs the Medicare program. So we are going to publish this in some way, whether it's in a peer-reviewed journal or on our database in some way that will actually, the goal is to give this information to clinicians who have to choose from these measures by which they want to be measured by, and so that they can actually choose the ones that are best supported by the best evidence. You always have to end a presentation with a smile, so it's my favorite UVM costume. Okay. Leave the smile up there. Right, thank you.
I think we've got time for one or two questions. Yeah.
So I have a bit of a perhaps different question. So I'm interested in changing poor quality that is found in routine practices, right? So for example, in relation to medical interventions that are deemed unnecessary by the evidence. So for example, routine episiotomies, routine administration of LARCs, immediately after childbirth whilst prescribing exclusive breastfeeding. How or not could your measurement tool apply to this?
That would be applying an innovative application that we've done of EBM methodology. Just take that, you could play around with the criteria, see if you think that the evidence that you can find, or you could look at what we have and start there. It's often a good starting place. May not be everything, but we have a lot of stuff. May not be everything, but we have a lot of information there. So look at the actual evidence. Do what we do, which is it takes 1.5 pages, or a page just to write it out, show you what a review looks like. I could send it to you, it's sample review. This is what the measure, this is what the intervention is. This is what people are doing. This is what the criteria are. This is what the evidence shows. This is what the guidelines show. Just take it there. Take it to the people who are implementing the policy. Take it to the clinicians who are following this particular thing. I mean, it's work. I'm not saying it's easy. None of this is easy. But this is how you might apply this kind of thinking to that kind of problem. There's another question there, but I want to make sure there are others.
Yeah. Okay.
To what extent has this process been accepted in the US? And we know in South Africa.
The process of implementing quality measures, it's extremely common in a variety of settings. Okay, so all employed physicians at a hospital, for example, all hospitals are subject to these sets of measures. Any physician in private practice who accepts Medicare patients will be monitored in this sort of way. So it's increasingly more and more widely used in the private sector and in the public. This is the biggest, we're after the biggest, reimburser of all, Medicare. Bernie Sanders just introduced a new bill, Medicare for all. It's Medicare that covers everybody over the age of 65. So tens of millions of people are covered by something like this. And the reimbursement model is changing from the previous fee-for-service to this, whatever you want to call it, pay for performance, pay for value, whatever. Some piece of the financial pie is being more and more allocated to this kind of analysis.
What is that percentage?
So, as shown at the front, at the right up front here, the Medicare is going to increase from now 4 or 5% to about 10% within 4 years.
Okay, so I'm going to give Leslie the last question, but before he asks, I just want to ask a question first. Most of the
Where's
evidence.
the hierarchy?
Yeah, I know he's going to ask you something which is going to maybe take a bit longer to answer. The evidence you presented is mainly biomedical in nature. Where is the qualitative evidence that also comes to bear on patient outcomes?
Exactly. So, are any of the quality measures asking, are the patients happy in your practice? The patient with this disease, are they happy with your care? Most of the attention here has gone on to the biomedical stuff. There is patient satisfaction. That's a component of this. We haven't really gone after that kind of information. I don't think there's a lot of it.
So just as an example, there's evidence to suggest that diabetic children, for instance, who have a supportive family, they're much better than other kids. So that's what I'm talking about.
Absolutely. But the patient satisfaction piece of this has not been the focus of what we have done. Okay. People will argue how you measure and
yeah, for sure. Leslie,
sir.
My last word is a question like this.
Surprised?
I can understand that this works really well for interventions, but I'm puzzling about sort of prognostic criteria because, for instance, cholesterol, forms of cholesterol, other risk factors becomes really complex. I mean, that yellow box must surely be filled up with all kinds of criteria to make it, to modify.
Well, things have changed. If you're cholesterol, we've spent about a generation going after levels of LDL and stuff like that, and we're changing. We've changed for the last 4 or 5 years. So that's not a measure any longer. It's not a measure that's actually being asked for people to do because the basic evidence has changed and basic sort of quote standard approach has changed. You don't treat to target of the LDL any longer. You treat to modify, risk status. So the measures themselves undergo change as the data changes. So we're trying to at least put out there some information by which the people who make the measures, who actually create them in the first place, can use to make better ones.
I guess I'm saying that the measures are so multifaceted that it becomes quite difficult to put in a box.
Well, that's
multiple risk factors.
It's part of the limitations of the measures themselves.
Okay, I just wanted to say that our head of department, Professor Myers, is traveling in England at the moment and he uses a politics.
Because he would have had the last one.
Yeah. Thanks very much once again.